Our next subject for discussion is anemias. When we think about anemias, there are a number of ways a person can get to be anemic. They can become anemic from blood loss, hemorrhage, they're losing blood. They can become anemic because their red cells don't live long enough. This is a hemolytic anemia, such as sickle cell or thalassemia. And they can become anemic because they don't make red cells due to some type of manufacturing deficiency. And this is where we're going to start. We're going to start with iron deficiency anemia. And I suspect that most of you know the symptoms of iron deficiency anemia well. Pallor, fatigue, cold sensitivity. Patients are apt to get dizzy easily. They may have brittle hair and nails. And the treatment for iron deficiency anemia, in addition to rest, is to give them what they need, give them iron. Oftentimes you might also be asked to get a stool for occult blood or a stool for guaiac, because a lot of patients, particularly older patients, may have a hidden GI bleed that just compounds and complicates an anemia. Let's look at a question. A toddler has been diagnosed with iron deficiency anemia. Which foods, if prepared by the mother, indicate understanding of the child's needs? Number 1, chicken pieces, carrots, and milk. Number 2, scrambled eggs, orange juice, and toast. 3, hamburger in a bun, corn and milk. 4, macaroni and cheese, peas, and milk. And the correct answer is number 2. If we look at number 2, we have the iron source in the scrambled eggs. The egg yolk contains iron. And we have vitamin C in the orange juice. When you have a question like this, you're always going to be looking for a vitamin C source. Vitamin C enhances the absorption of iron 7 times. Now, if you look back at the question, you'll note that chicken has a little bit of iron in it. It's not as good a source of iron as, say, eggs or beef, but there's some iron there. There's no vitamin C source. Carrots are vitamin A. They're not an iron or a vitamin C source. Milk contains no iron. In fact, milk reduces the absorption of iron. So number 1 is not a good choice. If you looked at number 3, some of you may have wanted to choose that because you said there's iron in the hamburger. That's true. And there's a little bit of iron in the bun. Enriched flour contains a little bit of iron. The B vitamins and iron have been added back to that. But there's no vitamin C source. And milk not only contains no iron and no vitamin C, it blocks the absorption of iron. And if we look at number 4, this is the worst choice of all. Macaroni may have a little bit of iron because it's made from enriched flour, but not much. Cheese, a milk product, has virtually no iron and blocks the absorption of iron. Peas are not a good source of iron or vitamin C, and milk blocks the absorption of iron. So the best answer to that one was the eggs that had the iron in the egg yolk and the vitamin C in the orange juice. Whenever you see a question like this, look for an iron source and a vitamin C source, and this is commonly asked on the exam. Now, if we talk about iron deficiency anemia and the administration of iron, if the patient is getting oral iron in a liquid form, would you use a spoon or a straw to administer it? A straw, because of course it's dark in color and would stain the teeth. Now, if you are giving iron liquid or capsules, pills of various types, if you wanted perfect absorption, you'd give it between meals on an empty stomach, but you'd make your patient sick. They would probably vomit. So most people recommend that we give it with meals. Even though the absorption is a little less, at least the person is going to be able to keep it down. So giving it with meals is what we usually do, and that decreases the nausea and vomiting that iron can cause. We've talked about giving iron sources with vitamin C. A listing of some iron sources. We talked about meats and eggs. We talked about enriched breads and cereals that have had the B vitamins and iron added back in. Green leafy vegetables are a source of iron, so spinach, broccoli is a good source of iron. You might also see iron in raisins. That could be another one that would show up on an exam item. Now I want to talk a little bit about giving an intramuscular injection. Iron must be given deep IM via Z-track. Now, when you're going to draw up an iron injection, you're going to draw your injection up. It's probably going to be a large amount, maybe 2.5 cc's. Sometimes you have to give as much as 5 cc's, which would mean 2 2.5 cc injections. So you're going to draw up the iron. You want to then change the needle because the outside of that needle is covered with a staining product. Iron is black in color and it stings and stains. So change the needle. Then as you go to administer the needle, administer the medication, we use Z-track, which simply means that you are going to pull tissue to the side. So select, usually it's a gluteal site that we want to use. You want to pull the tissue, prep the skin as normal, pull the tissue to the side, put in your injection, aspirate to check, make sure you're not in a blood vessel, and then administer as normal. All the time you're keeping pressure, pulling the tissue to one side. Now, after the medication, the injection is finished, wait a few seconds, oftentimes to let it settle a moment, and then withdraw the needle and the skin goes back. So then the hole in the skin is in one spot and the hole in the muscle is in another, and they no longer line up. That's what a Z-track is. When you use the Z-track, you seal it deep in the muscle so that you don't get any stinging or staining, and it can't ooze back through the tissues. It's that oozing back that really hurts. So iron must be given Z-track. We can give other medications Z-track as well, but iron must be given Z-track. Sometimes we use the airlock technique, where you actually pull back a little bit of air, like 0.2 cc of air, after you've drawn up the medicine, pull back about 0.2 cc of air. When you turn the needle right side up here, the air will rise to the top, and all that does is it just cleans the medicine out of the needle. You're not putting air into the tissues, you're just getting enough air in there to push all the medicine out of the needle. And some people will advocate using the airlock technique with a Z-track injection. Another question. The client is being treated for iron deficiency anemia. Which comment by the client best indicates compliance with the treatment regimen? 1, I think I feel better. 2, my energy level seems higher. 3, my cheeks are flushed. 4, my stools are now black. And the answer is number 4. My stools are now black. As you know, iron turns stools black. And notice it says are now black, so that means there's been a change in color. The other answers have a little bit of truth to them. The patient might feel better as their anemia begins to disappear. However, the one that best indicates compliance is the one that says my stools are now black. Now, another way they could ask that same information would be to say which observation by the nurse indicates the client is not giving, or the mother is not giving iron to their child as directed. And that would be light brown stools in the diaper, because iron will turn stools black. Another anemia that I want us to look at is pernicious anemia. Now, if you look at the picture, you'll notice that we've got a picture of a stomach here. B12 is in your food. Meat, milk, fish, and eggs contains vitamin B12. In order for vitamin B12 to be picked up from the intestinal tract and taken into the bloodstream, you need to have intrinsic factor. An intrinsic factor is part of your gastric juices. If a person doesn't have adequate intrinsic factor, they're not going to be able to absorb vitamin B12. The most common cause of pernicious anemia in the United States today is lack of intrinsic factor. Now, it is possible to get a nutritional pernicious anemia, which means if you are a complete and total vegetarian and eat no meat, milk, fish, or eggs of any kind, you could develop pernicious anemia. Unless a question specifically says nutritionally based, what you will answer on NCLEX is that it's the lack of intrinsic factor. Now, vitamin B12 has a number of functions. Vitamin B12 is necessary to make red cells. It's also necessary for the proper functioning of the nervous system. So that tells us the kind of symptoms that we'll get with pernicious anemia. So if we look at the picture, you can see that anemia, pallor, fatigue, this all has to do with the red cell problem. The paresthesias, paralysis, depression, psychosis relates to the nervous system issue. Now, wouldn't it be tragic to be on a psychiatric unit, either labeled psychotic or depressed, when what you needed was some red cell, some vitamin B12? I mean, this would be sad. There's another symptom they frequently ask about on the exam, and that's this sore mouth and the beefy red tongue that occurs early in the disease process. So don't forget that beefy red tongue in terms of a symptom of pernicious anemia. Now, it is probably possible to pretty much diagnose pernicious anemia by virtue of blood tests. However, sometimes they do ask us about the Schilling test, which has been done for many years, and some doctors are still ordering that to be done. I'd like us to do another question on pernicious anemia here. The nurse is teaching an adult who has just started treatment for pernicious anemia. Which statement by the client indicates a need for more teaching? 1, I will take my pills every day. 2, I know I will never get over this disease. 3, if my legs start to pain me, I will tell my doctor. 4, my husband is learning how to give me shots. Now, a need for more teaching. What is wrong in that is number 1. I will take my pills every day. This is treated by giving injections, and the injections are usually monthly. Now, they may start out the first week, they may have several injections, but after that, it's usually a B12 injection once a month. Now, statement number 2, I know I will never get over this disease, is true. Pernicious anemia that's due to lack of intrinsic factor is, well, I guess you could say it's similar to diabetes. Once you're missing insulin, you're missing insulin. Once you're missing intrinsic factor, you're missing it. So you're not going to get over intrinsic factor related pernicious anemia. Neuropathy is a sign of pernicious anemia, so legs paining you, you should call your doctor. And if you have to get regular injections, it's nice if a family member knows how to do it, even though the patient should be able to do it themselves, but it's nice. So there's nothing wrong with number 4. So a need for more teaching is that about the pills, because this patient will be getting monthly injections. Another question for us. A Schilling test is ordered for a client. What is the nurse's primary responsibility in relation to this test? Number 1, collect the blood samples. Number 2, collect the 24-hour urine sample. Number 3, assist the client to x-ray. And number 4, administer an enema before the test. The correct answer is number 2, collect a 24-hour urine sample. Now, with a Schilling test, they give the patient radioactive vitamin B12 by mouth. Then we collect a 24-hour urine specimen. So let's say this is supposed to go from 8 o'clock one morning to 8 o'clock the next morning. So you go in at 8 o'clock and have the patient empty their bladder. What do you do with that specimen? Discard it. Throw it away because it was made before now. Then you collect each and every specimen for the next 24 hours. At 8 o'clock tomorrow morning you go in, have the patient empty their bladder. What do you do with that specimen? Keep it. It was made during that 24 hours. Let's talk about another anemia, folic acid deficiency anemia. This is exactly what it says. You don't have enough folic acid. The key thing about this, I think, is important for us is that folic acid deficiency has been related to neural tube defects. So if a woman is deficient in folic acid when she gets pregnant, she's got a high chance of having a baby with hydrocephalus, anencephaly, meningomyelocele, with some type of neural tube defect. So all women of childbearing age who could possibly get pregnant ought to make sure that either their diet has adequate amounts of folic acid or that they take a 400 microgram tablet of folic acid. Now, diet sources, green vegetables, liver, yeast are good sources of folic acid. Another anemia we want to look at is aplastic anemia. Now, this is very, very serious. This is life-threatening. In aplastic anemia, the bone marrow doesn't work anymore. So not only do you have not enough red cells, you also don't have enough white cells or platelets. So if you don't have enough red cells, you're anemic. If you don't have enough white cells, you're immunocompromised. And if you don't have enough platelets, you bleed. Oftentimes, the cause of this could be a drug, for instance, a drug toxicity. If we know the cause, remove the cause, and hopefully the patient will get better. This is one where it's a lot of supportive care, so this patient would be on those neutropenic precautions that we talked about earlier. They would be on bleeding precautions that we talked about earlier. Sometimes patients like this might benefit from a bone marrow transplant, but it would depend upon the cause of the aplastic anemia. But it's a very serious problem and often can be life-threatening. Let's look at another kind of question here. A 1-year-old child is diagnosed with sickle cell anemia. The mother is pregnant with her second child and asks the nurse if the new baby will also have sickle cell anemia. She says that neither she nor her husband has sickle cell anemia. What is the best response for the nurse to make? Number 1, it is very unlikely a sickle cell is not inherited. Number 2, the new baby will probably also have sickle cell anemia. Number 3, there is a 25% chance that each child you have will have the disease. Or number 4, if the child is a boy, there is a 50% chance he will have the disease. Now we need to remember that sickle cell is transmitted as a recessive gene. So the correct answer is number 3. We're going to talk about that in a moment. But before we leave this picture, I want you to note that it says up here, neither she nor her husband has sickle cell anemia. Now what that is telling you is that they are both carriers. So that's a subtle way for them, for the item writers, to tell you that both of the parents are carriers. Now we're going to take a look at how recessive diseases are transmitted. We're talking about it in relationship to sickle cell. This is the same transmission, however, for other diseases, such as cystic fibrosis, phenylketonuria, and Tay-Sachs. Even blue eyes are transmitted as recessive genes. So we're talking about it now, but I want you to transfer this information to cystic fibrosis, PKU, Tay-Sachs when we talk about those. Now, if you look at the picture, you'll note that those are 2 circles. So we got mom, we got dad. The red side represents the sickle gene. So both of these parents are carriers. Neither one of them has the disease, but they are both carriers. We could get a sickle gene from mother and a sickle gene from father, and this child would have sickle cell. We could get mother's sickle cell and dad's non-sickle gene. This child is a carrier. We could get mom's non-sickle and dad's sickle. This child is a carrier. Or they could luck out and get the non-sickle from both mom and dad, and that child is disease and carrier free. So statistically, with every pregnancy, there is a 25% chance that each child will have sickle cell, a 50% chance that they would be carriers, and another 25% chance that they would be disease and carrier free. Now remember that the odds start over with every pregnancy. So just because you had one child with sickle cell doesn't mean the next two have to be carriers. You could have 2 or 3 children in a row with sickle cell. Likewise, you could have 2 or 3 children in a row that did not have the disease or that were carriers. But statistically, every pregnancy gives you a 25% chance of having a child that has the disease when both parents are carriers. And that's what they usually ask about on NCLEX. Now let's talk about what goes on with sickle cell. When a patient has sickle cell, these cells assume a funny shape, kind of a sickle shape or even an S-shape cell. Do they always sickle? No. Something has to precipitate the sickling crisis. And the most common cause of precipitating the sickling crisis is dehydration. Acidosis will do it. High altitudes with low oxygen tension will do it. But the most common thing that reduces the oxygen tension and causes the sickling is dehydration. So we have a patient who is dehydrated. The oxygen tension is less. The red cells now sickle. When they sickle, 2 things happen. The first thing that happens is they don't live very long. How long does a normal red cell live? That's right, 120 days. Sickle cells live about 1 to 3 weeks. Actually, I think it's 6 to 20 days, but 1 to 3 weeks is good enough to remember. So lysis, the breakdown of the red cells, they only live a week or 2 instead of 4 months. So no wonder the patient is chronically anemic. Now there's also another problem that relates from that, and that is that as those red cells are broken down, their byproduct of the breaking down of red cells is bilirubin. And the liver has to convert the bilirubin to bile, send it to the gallbladder where it gets stored, and then it helps to digest your fats and give your stool its color. In patients with sickle cell, they have huge amounts of bilirubin, so the liver is working overtime trying to break that bilirubin into bile, so to do its recycling thing, converting bilirubin to bile. So sometimes they get an enlarged liver. Sometimes they're jaundiced and icterus, yellow sclera, because the liver can't keep up with this high demand with the breakdown of red cells. Many times your sickle cell patients will even get gallstones when they're 20 years old instead of 50 like the rest of us, because of that extra amount of bile that's gone to the gallbladder. Now if that's all that happened, that would be a serious problem, but it's not. Something else goes on. So those sickled cells that are funny shaped don't go through blood vessels designed for round cells very well. So the circulation is slowed and there's clumping and thrombosis. And wherever you have the clumping and thrombosis distal to that, you get ischemia. So you can get kidney damage, extremities. In Africa, you'll oftentimes see patients with huge leg ulcers that never heal because the circulation to their legs is so poor. You could get stroke-like illnesses. You could get lung damage. People go blind. Children will present with an acute abdomen. You're convinced they must have appendicitis or some other acute abdomen syndrome, and it's the vaso-occlusive crisis that we get with sickle cell. Sickle cell is a terrible disease. It's extremely painful. It's like 100 awful diseases in one. Let's look at a question. A 1-year-old child is admitted to the hospital with sickle cell anemia in crisis. Upon admission, which therapy will assume priority? Number 1, fluid administration. 2, exchange transfusion. 3, anticoagulant, or 4, IM administration of iron and folic acid? And we said the number one cause of crisis is dehydration, so the answer is number 1, fluid administration. Commonly asked question on NCLEX. Now when we talk about sickle cell, hydration, hydration, hydration. So hydration is a major component of the management of sickle cell. Oxygenation is important, but this is not an airway issue per se. It's the lack of oxygenation can bring on sickling, and you can get that with the anemia aspect. Hydroxyurea, probably not likely to be on the exam. It's a drug that's been used with some success in the management of sickle cell. We don't usually give aspirin to people with sickle cell. Now you might say, why not? It's anticoagulant. However, aspirin is acetylsalicylic acid and can create acidosis that brings on sickling crisis. So pain is better managed without the use of aspirin. Another question for us. The nurse is caring for a 15-month-old newly diagnosed with sickle cell anemia. The child's parents ask why the child has not had any symptoms before now. The nurse's response is based on which knowledge? Number 1, maternal antibodies have protected the child during the first year of life. 2, breast milk is a deterrent to sickle cell anemia. 3, this disease does not manifest until the child begins to walk. Or 4, elevated fetal hemoglobin levels prevent sickling of red cells. And the correct answer is number 4. Babies are born with high hemoglobin levels, and this keeps the oxygen content up and prevents the sickling. Typically, the first sickle cell episode, the first sickling crisis, may occur in the toddler years when all of their hemoglobin levels have been used up, and if they are eating, particularly toddlers that drink a lot of milk and aren't eating a lot of table foods, they're apt to get the toddler anemia, and this is when they are apt to go into their sickle cell crisis. Remember, this is not an infectious disease, so it has nothing to do with maternal antibodies. Another question for us. Which statement is essential to include in discharge instructions to the parents of a child who is newly diagnosed with sickle cell anemia? Do not let her bump into things. She will bruise easily. Choice 2, notify the physician immediately if she develops a fever. 3, she will need special help with feeding. Or 4, observe her frequently for difficulty walking. And the correct answer is number 2. Fever can bring on dehydration. It's very important to teach the parents that if they get a fever, if the child has vomiting or diarrhea, anything that could cause dehydration, they need to get them to their physician quickly, much sooner than you would a child who did not have sickle cell. They need to be adequately hydrated, otherwise they can develop the crisis. Another question for us. Which statement by the mother of a child who has sickle cell anemia indicates a need for more teaching? 1, we are going to the mountains for our vacation this year. 2, it's a good thing my child likes to drink juices. 3, if my child needs something for pain, I will give her baby acetaminophen. 4, I will make sure my child doesn't get chilled outside. Now, a need for more teaching is number 1. Mountains are high altitudes. You would be much better off driving to the seashore than you would flying to the mountains for a vacation if someone in the family has sickle cell. One more thing that's important for us to consider about sickle cell, and that is who's at greatest risk for it. Sickle cell commonly occurs among people whose ancestry goes back to the African continent. We think that it started many years ago in Africa as a protection against malaria, and the trait does seem to indeed protect against malaria. But if you have the disease itself, I think sickle cell is worse than malaria. So the people at greatest risk for sickle cell are those whose ancestors have gone back to the African continent. it is thought that about 10% of African Americans carry the gene for sickle cell. Now, that doesn't mean that they all have sickle cell, but they carry the gene for sickle cell. We also see sickle cell in significant numbers of cases in people from the Middle East. So Arabs are very apt to have sickle cell. And if you think about it, that's at the top of the African continent. So people whose ancestry goes back to somewhere on the African continent are at highest risk for